The term holiday heart syndrome was first coined in 1978 by Philip Ettinger after observing a spike in emergency room visits for heart rhythm issues following long weekends and holidays. It describes the occurrence of acute cardiac rhythm disturbances, most commonly atrial fibrillation or AFib, in otherwise healthy individuals after a bout of heavy drinking. The exact mechanism is probably multifactorial, involving a perfect storm of electrophysiological changes. Direct toxicity, ethanol and its metabolite acetaldehyde can be directly toxic to myocardial cells, altering calcium handling and slowing conduction velocities. Sympathetic surge. Alcohol consumption triggers a release of catecholamines, epinephrine and norepinephrine, which shortens the atrial refractory period. Vagal stimulation. Paradoxically, alcohol can also increase vagal tone. This autonomic conflict between sympathetic and parasympathetic signals is a known trigger for atrial fibrillation. Electrolyte derangement. Heavy drinking often leads to dehydration and the depletion of magnesium and potassium, both of which are critical for maintaining a stable resting membrane potential. The hallmark of holiday heart syndrome is the paroxysmal nature of the arrhythmia. It typically occurs within 12 to 24 hours of a binge. Atrial fibrillation is the most frequent arrhythmia, up to 90% of cases, though atrial flutter and premature ventricular contractions can also occur. Patients usually report sudden palpitations, thumping in the chest, lightheadedness, dyspnea, or mild chest discomfort. While the name suggests year-end festivities, it applies to any occasion involving acute high-volume intake, like weddings, sporting events, or vacations. Diagnosis is primarily by ECG, which will show the classic irregularly irregular rhythm and absence of P waves if the patient is in active atrial fibrillation. In many cases, holiday heart syndrome reverts to sinus rhythm spontaneously within 24 hours as the alcohol is metabolized and electrolytes stabilize. If the ventricular response is too rapid, beta blockers or calcium channel blockers may be used. Because holiday heart syndrome is usually an isolated acute event in a patient with a low CHA2DS2 VAS score, long-term anticoagulation is often not indicated unless the AFib persists or the patient has underlying risk factors. While holiday heart syndrome is often considered reversible, repeated episodes can lead to remodeling of the atria. Chronic heavy consumption can eventually lead to alcoholic cardiomyopathy, characterized by biventricular dilatation, reduced left ventricular ejection fraction, and myocardial fibrosis. Here is a comparison of acute versus chronic effects. Onset acute post-binge in holiday heart syndrome, while it is chronic years of heavy use in alcoholic cardiomyopathy. Primary issue is electrical arrhythmia in holiday heart syndrome, while it is structural dilatation of failure in alcoholic cardiomyopathy. Reversibility. It is highly reversible with abstinence in holiday heart syndrome, while it is partially reversible if caught early in alcoholic cardiomyopathy. Key finding is atrial fibrillation on ECG in holiday heart syndrome, while it is low ejection fraction on echocardiography in alcoholic cardiomyopathy.